Good evening, everyone. This is Stephanie Coleman, the family and autism educator at Kansas Lend at the University of Kansas Medical Center. It's been a while since I've done one of these. I think it was back in May, so it feels a little out of sorts to get back into this tonight. I just want to let you all know, first and foremost, if you have your video camera on, we are live streaming this on Facebook, and when the PowerPoint is down, they will see your face in your video on Facebook. So I just want to let you know that. So you might want to turn your video off when we aren't using PowerPoint. But we're really excited to bring this one to you tonight. What is an autism evaluation? If you don't know what Kansas Lend is, Kansas Lend is Leadership Education in Neurodevelopmental and Related Disabilities, hence the word Lend. It's pretty long, so we kind of shortened that for everybody. It's really nice. But it's an interdisciplinary training, workforce type training that works with many different disciplines to really enhance their leadership skills and advocacy skills, but then also work together as teams for those that they're going to, in the future, work with individuals with developmental disabilities. So this just tells you a little bit about who we are and who our partners are and where we are funded. And I am going to, before I turn it over, I just want to say two things. If you have questions, please put them in the box, chat box. We will get those answered. And if you are watching on Facebook, please put them in on Facebook and we will get them asked for you as well. So again, thank you for joining us, and I'm going to turn this over to Dr. Swails.
All right, hi everyone. My name is Leni Swails. I am a psychologist at KU Med, and we're looking forward to talking with everyone this evening about autism interdisciplinary evaluations. I am, like I said, a psychologist at KU Med, and I spend half of my time doing clinical work, a lot of which is autism evaluations for young kids all the way through age 18. And then I also spend some of my time clinically doing treatment. So I do ongoing behavioral therapy and cognitive behavioral therapy for kids and teens with autism. I spend the other half of my time participating in grants like Lend, where I do a lot of community outreach and teaching and training the community about autism and also mental health and behavioral interventions. So I'm excited to be with everyone this evening.
Wonderful. And I'm Julie Mujica. I'm a speech language pathologist, and I'm also a clinical instructor with the Hearing and Speech Department at the University of Kansas Medical Center. So my role is I teach graduate students how to do the job of being a speech language pathologist. And I also work in the clinic setting, providing autism evaluations and developmental evaluations to kids birth to 3. So I see the really little ones. And then obviously I am also a part of Lend on faculty there, and thrilled to be here tonight to discuss this really important topic. So before we begin though, we want to get a sense from you all, what do you think of when we say autism interdisciplinary evaluation? Feel free to use the chat box or shout it out if you have something on the tip of your tongue. Maybe this is why you all are here, because it is kind of this well-kept secret. So we are going to take you through today what a lot of people probably envision of the actual in-person evaluation when you come into our center. But before comprehensive evals, thank you, Melissa. Yes, exactly. It's a very thorough evaluation, right? Really making sure that we understand all aspects of development. Absolutely. So a lot of us think of that in-person portion, but we really wanted to take the time tonight to identify and recognize that that is one aspect of this whole process that families go through. So we put this in a little graphic. It's simplified because it's a straight line process, which we know human nature is not straight line, and development is not always in a straight line either. But we propose it as a way of simplifying and organizing tonight's discussions about what is an autism interdisciplinary evaluation. So when we think of where we start, it typically begins with this act of noticing differences or delays in developments. It also might be that families are noticing certain strengths or like unique abilities in their child. For example, like early letter awareness. Wonderful. The noticing stage might be internalized by families as concerning, or it may not be to them. And it may be that other outside sources are bringing up concerns, or screening measures are identifying a need for further evaluation. So we're going to take some time tonight to discuss strategies on how to approach these important but often difficult conversations of noticing the potential need for a developmental evaluation, or noticing the signs and symptoms of autism. And the second phase that we really want to dive into is this seeking or guidance phase that a lot of people go through. So it could look to looking for medical providers for answers, or therapists, or looking to your loved ones for guidance. A lot of people go onto the internet, and type in different behaviors they're observing. So we want to talk about what happens during this stage, and also what happens with this reality of there is some wait time as families are trying to pursue the next step of a formal autism evaluation. So that'll lead us into kind of that third big process of acting on what you're noticing and what you found out. Dr. Swails will take us through the formal evaluation process, what happens there, the logistics, the assessments, why it's important to have such a comprehensive evaluation and assessment. And then lastly, we're going to talk about sharing and disseminating the information, because the response to a diagnosis or no diagnosis of autism, it can result in a lot of different emotions. So the information gained also leads to a lot of individual and very personal decisions. So we want to talk on how to sift through the who, what's, whens, and wheres and hows of sharing information to best support families in this situation and support their child. So in my clinical experience, I've heard a lot of families and child care providers and other important people in the child's life state that, yes, I noticed differences, but I didn't know what it meant. So sure, I realized that they're doing something a little unusual, or maybe not that their peers were doing, but I didn't know how to map that onto meaning that they were possibly showing signs of autism. So we thought it was really important to start tonight with a clear understanding of how, as a team, we come to a diagnosis of autism. So the table in front of you is from the DSM5, which stands for the Diagnostic and Statistical Manual of Mental Disorders, the 5th edition. And this is the criteria that is used to identify the presence or absence of autism spectrum disorder. So if we really want to break it down, there's two big domains that we're looking at. We're looking at social communication and interaction, and then we're looking at restricted, repetitive patterns of behaviors, interest in those activities. And within those two groups, there's additional specific criteria or deficits, as you can see in this second column here. So to meet criteria for autism, an individual must show deficits in social emotional reciprocity, in differences in their nonverbal communication that they use, and difficulty in developing and maintaining and understanding relationships. So all three of those aspects put together is how we describe an overall deficit in social communication. Now, the restricted and repetitive patterns of behavior area, an individual would only need to meet criteria for 2 out of the 4 elements in that aspect. So that includes stereotyped or repetitive motor movement. A lot of times people observe different uses of the individual using their body in different ways, use of objects like spinning the wheels or lining up cars, and differences in speech sounds and how they use language. It could also be just this insistence on sameness, or a really, really strong interest in one thing that gets in the way of them participating in other activities, and sensory differences. So this is the criteria that any autism evaluation has to use their assessments and observations to establish if there's the presence or absence of autism. So let's talk about what this might look like in, let's say, a classroom or in your house, and where you can get reliable information on what signs and symptoms to look for. If you want to move to perfect.
And feel free to say slide if you want me to move on to the next slide.
Okay, that'll be our code word.
Yeah.
Slide. So I think this is really important because a lot of times families are saying, well, I don't know, why does it matter if, you know, they don't want to play patty cake at 12 months? And you can see some of these skills that we're looking for, which are evidence for either the ability to go back and forth in a social interaction, or evidence of the ability to use nonverbal communication. So that's why gestures and pointing are so important when they're younger. You know, pretend play actually really shows that a child is understanding a relationship. They have to understand who the doctor and the patient relationship. So these are why some of these signs and symptoms we look for, that's how they map onto us making a decision if they meet criteria for autism or not. Now, it's important to recognize that as a child or individual develops, there's obviously different social demands. So we wanted to include on here some signs and symptoms for an older child, possibly. So maybe difficulty with friendships, having a hard time picking up on social cues, so like reading body language, sarcasm can be tricky, figurative language can be really hard, or taking turns in a conversation. But again, there's a lot of information out there that can be overwhelming. So we wanted to tonight also use this opportunity to link you to really reputable websites. So the CDC we've linked there is an excellent first place to start. Okay, slide. I'm learning. So in terms of repetitive and restricted behaviors, these might be some things that are noticeable by teachers or parents, like following certain routines, or when we say focus on parts of an object, you know, that might be like just spinning the little wheel or opening and closing the door a lot. Having things to be in an order, or more interested in manipulating an item instead of like engaging in some of that pretend play. Also, this is where a lot of sensory things get caught. So, you know, difficulty with clothes or particularities around food textures and temperatures, things like that. But again, you can see how it can be tricky because a lot of children, you know, are picky eaters or have some sensory differences. So it's really when we're looking for a cluster of symptoms and things that are getting in the way of learning. So that's a really important thing to remember. Okay, next slide. So this is a very valuable list of associated characteristics. So these characteristics that you see do not always occur in autism. They do not have to. They're not part of the criteria, but often these difficulties can co-occur, as can these medical diagnoses or mental health diagnoses. So we just want to highlight this fact because it really points to the necessity of having an interdisciplinary team, because there's a lot to tease out and differentially diagnose, and you need to be able to provide appropriate recommendations. So you need a full team to support all of these possible related medical conditions or delays in development. So for us, I mean, I know Leni and I can speak that it's really wonderful to have access to a physician for a child who might have a seizure disorder or, gastrointestinal issues. And it's really wonderful for me as a speech therapist to have a psychologist right there to help with some of those moods and emotional reactions and teasing out anxiety. So we did want to highlight this because that leads into why we have so many team members for an autism evaluation.
And I just want to add in, I'm always surprised by kind of the high co-occurrence rate between autism and some of these things. So about 25% of kids with autism will experience a seizure. And so that's a reason why we're super careful about screening for that and making sure that that's part of the conversation. The other thing too, is if you think about ADHD and anxiety, there's a really high co-occurrence rate there. So I think it's something as high as like 60% of kids who have autism will also have co-occurring ADHD or anxiety. So that's a reason why it's kind of routinely something that we're looking into.
So when I think about all this information and the role of everyone in this child's life, I'm not really wondering if anyone in this group has ever felt the need to have this difficult conversation and bring to a parent's awareness. I'm really wondering, how many of you have done it multiple times, because we all know a child that we've had some concerns about, and it's a very delicate conversation. So we wanted to take this time to give some strategies. Now, obviously, as with all relationships, so much of the conversation really depends on nature of your relationship. So these are not you have to do it this way, but things to consider if you have a child you're concerned about, maybe in your classroom or in your family or a close friend. So the first one is acknowledging parents' concerns. And as I was, reading through and thinking on my own personal experience and my own clinical experience, there is a common theme that a lot of parents speak to being told, "Don't worry." And that's a pretty natural reaction. It feels like you're relieving stress and, it is a coping response we see. However, that's not very helpful to the family or to the child because it delays intervention and it delays the process. So our first piece of advice is to just acknowledge. You can never go wrong with listening. So if a parent is bringing concerns to you or noticing any sort of behaviors, it's very appropriate to listen to them, reflect back what you hear them saying. Okay, so I hear you saying that change is really hard. And let the parent express themselves and share what information is comfortable for them at that time. It's also fine to ask some open-ended questions like, so, what are you thinking about all of this? Get a sense of where they are, and always offer support. It is okay to come back to a conversation too. So another recommendation is to plan a time where you can focus on the conversation, where both people are safe and there's less distractions. When you're starting more of an initiated conversation regarding the possible need for a referral, it is recommended that you start with the parent's own observations, their words, and then build from that. Start with the child's strengths and keep it very observable. I've noticed this. I've seen this, specific actions that you've seen. It may or may not be beneficial to use any form of a diagnosis or label. What's most important is that you keep it positive and calm and more action focused. So suggest a reputable online source so the family can be empowered to go research what they're noticing and what that might mean. And then ultimately encourage them to talk to their pediatrician. The language that seems to be helpful is more of like a proactive stance, maybe just talk to them to rule out anything serious or to get more understanding of how you can help. Those sorts of language and phrases can be very helpful. But it's also important to go into any discussion and expect a variety of reactions, because it's a very emotionally loaded topic for some people. For some people, it might be a relief, and they might say, well, thank you. I've been wanting to know who to go to with all this. I've been sitting here alone with it. And sometimes defensive mechanisms come up. So just preparing for all different types of reactions is really important when you're noticing signs and symptoms of autism and you're trying to communicate that with the parent. Anything you'd like to add, Stephanie or Dr. Swails, to that? There's a lot of different caveats and nuances to those sorts of conversations.
One thing I was thinking is that we have a picture here of the CDC Milestone Tracker App, which is a favorite resource. It's for specifically for kids. I believe it's under the age of 5, and it's a free app that parents can download in either English or Spanish. And it gives you prompts based on, and you can like add a child, where you can add kind of de-identified, like they would add, you know, if they have 2 kids, they would add 2 profiles. And then for each of those kids, you can track, and it prompts you based on the child's age of like what milestones you should be monitoring for. And then if the child shows significant delays or red flags for autism, it'll prompt the parent to share this information with their pediatrician. The really nice thing about it is, since it's storing, it's confidential and safe, but it's storing those milestones in that app, it helps to facilitate that conversation between the parent and the pediatrician, because then you're like, okay, these are the milestones we've been seeing, and these are the specific ones that raise the alert on the app for me to share this information with you. So it can help empower families to communicate that information in a way that'll be understandable for their pediatrician.
I would also add on that app, though, encouraging parents to, whether you're a doctor or childcare provider, to encourage those parents to put that app on their own phone and follow their own children, so that when you might share that information with them, and they don't get as defensive as you might think, because they're seeing it on their app too, and they can say, oh, it's not just me then that's worried. So I would encourage that whenever possible.
Absolutely. And depending on if you're in a school setting or a childcare placement, you might also have some developmental screeners available to you that are part of, parent-teacher conferences or progress reports or end of year. And, having that specific information is very helpful going into these. So you can also refer back to your team at your school. Okay, thank you. Let's see, next one. Yeah, so we've talked a lot about how bring it to your pediatrician. Pediatricians are obviously a key player in all of this. And so the first step is to go to them, ask for the consult, bring the app information, bring the concerns from loved ones, from teachers, and schedule a time to really talk about the next steps. The pediatrician is able to make a referral to a developmental evaluation or an autism evaluation. And they also, at all well child visits now, are evaluating for development in general, but many pediatricians are also using autism specific screeners. And so that tends to be sometimes some of the first awareness a family has about, oh, okay, I might need to further pursue a developmental evaluation. So all of that information from the pediatrician gets sent on to the team at the autism evaluation, and we're able to understand the reason for referral and some of the results of those screeners and aspects like that. So unfortunately, the reality is, though, that there's quite a long wait from that point of referral to the developmental evaluations to being seen. And obviously, it's multifactorial why this is happening, and below we've listed some of the reasons. There is a lack of providers who will have enough specialty training in this area. Also, as we talked about, because of the co-occurrence of so many different diseases and disorders, we need multiple team members on a team. And so that takes up more providers. It's also a behavioral assessment. So there's no blood work to be drawn or a one quick screening test. So it takes a long time to complete, as we'll go through when we discuss the actual in-person evaluation. And then we've also talked about the overlapping features. So we have to be very thorough and make sure that we're really understanding what's happening in a child's development. And I think it's a great thing that we've had increased community awareness. I mean, we have all of you here with us today. People are aware of the need to make these referrals because they're starting to recognize the value of early intervention and of getting a diagnosis to provide more services to a child. Okay, next one. So while there's waiting time, it's also important to know that there's a lot of active steps that a family can take that are backed by research to be helpful and beneficial. And one of the first ones is go ahead and scheduling a hearing and vision exam. We know, for example, hearing loss can actually result in some social differences in interaction. It can look like less eye contact because of avoidance of spoken language interactions. So it's really important to rule out these sensory differences as a primary causal factor or maybe just a compounding factor of the communication for an individual. Because we do know that an individual may have hearing loss or vision impairment and autism, or they may not have hearing loss or vision loss, but they could have autism, or they might not have autism, but they have hearing and vision impairment. So that information is essential as we think about recommendations, but also as we think about accurate diagnoses. The other thing is there's a lot of wonderful therapeutic options out there that can be pursued through private insurance. So like behavioral mental health, occupational therapy, speech and language therapy, physical therapy. And then there's wonderful programs like early intervention services in Kansas, that's called Tiny K, and in Missouri, it's called First Steps. And families can also access services through the school district, through special education services. Each of those programs have their own evaluation and eligibility process, but a child does not have to have a diagnosis or a medical diagnosis to receive services. It's based on functioning and needs and the eligibility requirements of those specific organizations. And then families also are the best advocates, and unfortunately at this stage, often the managers of all the information. So we also say use this time to keep record of any screeners, any evaluations reports and progress reports. And I think I saw a question about the age.
Yes. So at what age will the school district help?
Yeah, so if your child is enrolled in early intervention services, then that transition plan is seamless, that the child at age 3, if they're eligible, would transition. Otherwise, the school-based services begin at age 3. Does that make sense? And I see Dr. Swails is doing a lot of good stuff in the chat there. Will they get all daycare? Oh, that's a great question. And we will get to that in terms of the sharing information. And it really depends on the independence, each school district and the evaluation and the needs of the child in their level of need to access the academic curriculum. So.
I will say that for preschool services, it's not always the case, but for the most part, the maximum is usually like 4 days a week, half day, for the 3 to 5 program. And then as far as services for older kids, is it okay if I talk on that one? So I'd say like 95% of the time, these are random made up numbers based on my clinical experiences, that most of the kids I see for autism evaluation would benefit from behavioral therapy. The reason why I'm saying that that's so common is, one, there's a really high co-occurrence rate of autism with mental health conditions like ADHD and anxiety, which all those conditions would all benefit from mental health interventions. But also there's a really high co-occurrence rate of things like meltdowns, outbursts, tantrums, or aggression. And we see those things not just in kids who are diagnosed with autism, although it's very common in that group, but also individuals who are referred for autism eval and don't have autism often have a behavioral or mental health diagnosis that explains the characteristics that look like autism. So in the vast majority of the time, we will make recommendations for someone to seek outpatient therapy with a social worker, a counselor, a psychologist. And so something that I always feel really passionate about is, gosh, when I see someone and they've been on a wait list for a really long time and they're having these really significant behavioral difficulties, there's no reason they couldn't be referred for those behavioral therapies at the same time that they're waiting for that autism evaluation. And those behavioral and mental health interventions, often that's also what we're really strongly recommending both for younger kids as well as for older kids too. And sometimes more of those like anxiety or depression can crop up more for those older kids, especially if they're becoming more aware of differences socially between themselves and their peers. So that would be a big recommendation of things to start for older kids while they're waiting for evaluation. And Christy, on your iPhone, let me know if that didn't answer your question. All right, do you want me to go on to the next slide?
I think so. Yeah, I'll hand it over to you.
Oh, okay, great. Okay, so I think an important thing to consider too is ultimately, what is the purpose of doing this kind of evaluation, right? And so it's really not for giving a label for label's sake. Sometimes I hear that as a reason why families are really hesitant to pursue evaluations, because they're like, I don't want to label my kid, which I really understand, being thoughtful about. At the same time, the real purpose of doing an autism evaluation is to help inform ongoing interventions. So I often think about autism as something that lends an individual a lot of unique and really cool strengths that make humanity like interesting and diverse and fun, right? And that's part of the reason why I love working in the autism field, because I love working with people who think differently than I do. And that's a fun opportunity that you get when you work in autism specifically. But the other thing that's different about autism is there's also things about it that can make the world an uncomfortable place. If you're someone who really has that need for consistency and rigidity and routine, that can make life really uncomfortable, right? And similarly, if you're someone who has a lot of sensory differences, that can make the world really uncomfortable, or the same with social difficulties, right? And so really the purpose of an autism evaluation is to help optimize that person's functioning in the world, to take those pieces of the world that are feeling uncomfortable and to provide some interventions to help support them in that area. And I think that helping understand if autism is a part of what's going on, understanding that can help improve the family's understanding of that individual or the individual's understanding of themselves. And we're going to talk a little bit more about, how and when to share with kids or teens their own diagnosis. Ultimately, in a lot of ways, understanding a diagnosis is a way to help make sure that the interventions we provide are really going to be targeted and effective for that person's needs. So if we know that someone has autism, then we can better tailor even some of those behavioral and mental health interventions, or better tailor some of those social skills interventions or academic supports, right? The other reason why we provide, that's important to provide an autism evaluation, is that sometimes there's specific programs that someone might need to be able to access. And unfortunately, those doors may not be open unless a specific diagnosis has been confirmed by a medical provider. So for example, there's some specific like waiver programs through the state, like the Autism Waiver Program for children under the age of 6, that may only be available if someone has a formal diagnosis of autism, right? Sometimes there's specific school supports where they're kind of wanting to have that confirmation from an outside group about the diagnosis. Although I'll also say if someone has a need, then we want to make sure we're thinking about serving that within the school setting. And then also some autism specific treatments such as ABA or applied behavior analysis are sometimes only covered by insurance when a child has a formal diagnosis and evaluation for autism spectrum disorder. So we're thinking about getting that answer, informing ongoing treatment and care, access. And then the last thing is, remember I said there's all these co-occurring conditions, right? Well, we want to make sure we're really thinking about, hey, this is someone who might be at higher risk for some other things. And we want to make sure we're thinking about that carefully because we want to provide care for all aspects of that. So if someone has autism plus ADHD, well, we want to make sure we're also treating that ADHD. That's really important. And so part of the evaluation is thinking about, okay, so if I know this person might have autism, I need to think about these other things too. Then I want to make sure we're following up on that.
Leni, I just want to add here about what the purpose of the evaluation is from a parent perspective. You know, it really helped me get answers. For those of you who may not know who I am or anything about me, I do have a son who is 26 on the autism spectrum, and he was diagnosed relatively late in 2010 at the age of 14. But I didn't have the answers to properly help him be successful in life. I had went thinking he had depression, and I went and sought out a psychiatrist for that. And the psychiatrist said, has he had ever been evaluated for autism? And of course, at that time, I didn't know anything about autism, but it has once I got the diagnosis and I've learned more and more about autism over the last 10, 12 years, all these light bulbs have gone off and said, oh, that's exactly who he was. This is what he does. And I don't ever label him. It's just that it's, okay, these are the supports that are going to make him successful. And currently he is a senior at the University of the Ozarks. So he's got 3 more semesters left. And if we didn't get the diagnosis and have the IEP in school and the proper supports, I don't know where we would be right now. So like Leni said, it takes all kinds of people in this world to make it go round. And I would never, ever think my child any differently just because he has a label. So I just want to share that.
No, thank you, Stephanie. I appreciate that. Especially kind of thinking about that parent perspective, because that's not an experience that I have from that lens. And so in addition to co-occurring mental health, which is where my brain goes because I'm a psychologist, other things we also want to think about are co-occurring cognitive and developmental functioning. So about 20% of individuals with autism will have significant delays in cognitive functioning. And so that's something that we always need to make sure we're following up on. And then also, you remember we said there's that high rate of seizure activity and GI problems. So we need to think about all those things too. So thinking about the structure of a typical evaluation, we want to make sure that medical and developmental history are something that needs to be addressed. So if you look carefully at the DSM criteria for autism, which is like the medical definition of autism, it says that these characteristics have to be present in early development. And so because of that, we always make sure we're getting a careful, detailed developmental history to see if we're able to see some of those early signs and symptoms earlier in development. Now, just because those signs and symptoms might be, in retrospect, noticeable earlier in development, sometimes it's not something where like the social differences or other things could be really apparent until someone gets older and maybe the social expectations get more complex. So for example, if we're thinking about what's expected of a 3-year-old socially, that's really different than what we might expect of a 15-year-old socially, right? And so you could imagine a situation where a young child is really cooperative or does well in like physical play, where they don't have to navigate social nuance quite as much as a young child, but the social demands become a lot more nuanced and subtle as someone gets older. And so you might see, that's also why sometimes we might get referrals a little bit later, even though earlier signs and characteristics, when you talk about it retrospectively, can be identified. Sometimes this is hard for families to talk about kind of that developmental history, because sometimes there's a feeling of guilt of why couldn't I get in sooner, or people didn't listen to my concerns sooner, or why didn't I recognize that? I think it's important for teachers and providers in the group to recognize there's a lot of guilt that goes along with that. And also for parents to understand that that's common. You're not alone in that feeling. Although I would challenge you to wonder if that's parent guilt you're putting on yourself. Because I think there's often a lot of good reasons why someone may not be referred for evaluation until they're much older. So that was my long-winded way of saying medical and developmental history are really important. Oh, one more thing about that, actually. About 25% of kids who have autism will also experience a regression or a loss of skills between 18 and 36 months. And so what that might look like is a child who is meeting developmental milestones, was acquiring words, and then lost that skill and no longer was using single words, or was smiling, making eye contact, playing peekaboo, and then became very withdrawn or introverted and was no longer interested in that social engagement. Because there's that group, we look really carefully at developmental history to see if that child experienced a regression of that type, of that language and social type around 18 to 36 months. Okay, so that's medical and developmental history. The next part of the evaluation that's important to consider is that we have to make sure we're using standardized and evidence-based assessment tools and parent questionnaires. So that way we know from provider to provider that we're all using the same criteria to determine whether someone's truly showing some of these characteristics of autism. Some aspects of autism can be really hard to define at times, like social reciprocity. Like, how do you know if someone's really having delays in social skills? Where's the cutoff for that? Like, how do we know? And so that's why it's important to have standardized measures, because then we're able to consistently say, like, yes, this is kind of where we'd expect someone's skills to be. And this is how we can say, you know, for this person's age or for this person's communication or developmental level, there's a difference. Those standardized measures are both based on interaction, which we're going to talk more about in a minute, as well as parent questionnaires. And then usually there's two areas we're thinking about here: autism specific assessment tools, which is usually comprised of both an interview with the parent, as well as an autism specific observation based tool. So one where the child is doing different things in the assessment clinic and being observed for possible characteristics of autism. And then the other area that we're looking at is all those co-occurring things. So pretty regularly we'll do an assessment of communication skills, which is why we like to have SLPs on our teams. And then also because of that group of kids who have cognitive delays, we're usually doing some sort of IQ measure or cognitive measure for younger kids who may not be ready yet for IQ testing. And then also looking at those behavioral mood difficulties and adaptive behavior. And adaptive behavior is like self-care skills or someone's ability to do things independently in their daily life. Another really important part of the evaluation is doing a thorough record review. We know that oftentimes these kids have already had lots of supports before we get to see them for an autism evaluation, and we want to see what those supports have looked like. Especially at KU, and I think a lot of places too, but we pride ourselves on it at KU. We really value the input of the school. A big part of autism is social interactions, and we don't get to see kids around other kids here. So we really rely on teacher report. So because of that, we'll send out questionnaires for people to get their teacher to fill out in advance of the appointment, because we want to know in a classroom setting amongst their peer group, what do those interactions look like, and what do those relationships look like? So if you're a family thinking about evaluation, or if you're a provider advising a parent, we get so excited when we see therapy records, IEPs, and any kind of school report of social skills. And I think all autism providers get excited about that stuff. So when we're talking about an interdisciplinary evaluation, that looks different ways in different places. Often there's a psychologist involved, a developmental pediatrician, which is a pediatrician who's done extra fellowship time specializing in autism and other neurodevelopmental disabilities. Often we have speech language pathologists involved, who specialize in communication skills, both receptive and expressive language, as well as pragmatic language, which is like the social use or pragmatic uses of language. Julie, feel free to jump in as I'm speaking for a speech.
And speech sound development, as well as we also are specialized in feeding and swallowing and cognitive communication. Yep.
And then here we also have nurse practitioners involved in interdisciplinary evaluations. And we don't have this at KU, but at other places, they'll often have an occupational therapist involved too, because they can provide a variety of expertise, but especially related to sensory differences. So for our evaluations at KU, the composition of those teams is usually a psychologist, either a developmental pediatrician or a nurse practitioner, and a speech language pathologist, with a little bit of variability of the number of providers on the team based on the age of the child. And the reality is, this type of interdisciplinary evaluation is not available everywhere. And given the long wait list in our country, it may not necessarily be the only answer for how someone could get an autism evaluation. However, a lot of insurance and community programs will require that a Ph.D. or Ph.D., which would both be psychologist-related degrees, or an M.D. is involved in the evaluation in order for them to like count the diagnosis towards those access for waiver programs. So thinking about some of the autism-specific assessment tools. Oh, Teresa, that's a great question about age at which a child can be diagnosed with autism. We know that we can pretty reliably diagnose autism as young as 18 months of age. However, oftentimes the really young children referred for evaluation, like at 18 months, might have more significant or overt symptoms of autism. And so for someone who might have less overt or less obvious symptoms of autism, they usually wouldn't be referred that young. I think the average age of diagnosis in the US right now is about 4.5. But I wonder how much access and long wait lists is influencing that number. ADHD is something that is usually around age 4, because one thing that we really strongly consider is school functioning. So wouldn't typically diagnose that before a child's in at least a preschool setting. But in cases where it's really significant or severe, that could be diagnosed younger. Good question. Oop, I almost jumped ahead. Okay, so autism-focused assessment tools. I'm a research nerd, so I like to know, what does the research say about what's the most effective tools at identifying correctly individuals who have autism? And this 2012 study that I love found that there's really 3 tools that are the best. The first tool that I have on here is the Autism Diagnostic Interview Revised, or the ADIR. That's a measure that's really just based on parent report. It's a really good tool. The problem is it's unrealistically long for most clinical settings. And so it's one we're trained on, but don't typically use here. The Childhood Autism Rating Scale, or the CARS, is one that if you look at it as, it's based on a combination of observation and parent interview. And so that's one we use pretty commonly. However, it's also one that if you look at the specific data, it's strongest, or it's best at identifying kids with autism when it's also combined with the ADOS, which is usually everyone's favorite autism assessment tool. So at our clinics at KU, we typically do the CARS and the ADOS together because of that research showing that in combination, that's a really strong evaluation tool, and it's a reasonable length. And so I was saying here that these have high specificity and sensitivity. So meaning that We want tools that don't miss anyone. So we don't want to we want to make sure it's not missing anyone who might have autism and they don't come up significant on that tool. And we also want to avoid false positives. So we also don't want to capture people who the tool says they have autism and they really don't. So these are tools that have high sensitivity and specificity. Catherine, I'm going to have you bookmark.
There was one question, and I'm not sure exactly where it could go in here, but is there a big difference between behavioral evaluation and diagnosis? And I'm not, go ahead.
No, it's okay. Catherine, I'm not sure if you can, if you're available to unmute, I'd love to get a little bit more clarification about what you're wondering about here.
My question is because my son got he was referred for his pediatrician at 3 years old with a behavioral specialist, pediatric behavioral specialist, and they gave us a like a report. And she said that he is in the spectrum and everything, but I'm not sure if they count like a diagnosis or is totally different evaluation to the
So I'd probably
diagnosis.
look and see, did they use standardized assessment tools as part of that evaluation? Like, did they use the ADOS or the CARS or another standardized assessment tool? And then I would also look and see what are the credentials of that behavioral specialist. Was it a PhD? Was it a PsyD? Or was it MD? Was it one of those types of degrees that I was mentioning before that are ones that are commonly accepted for that?
Oh, okay.
Catherine,
Thank you.
if you'd like, I'll send you my email address and you can email me some more information, and then I can work with Dr. Swails and see if we can figure anything out for you on that one. Okay.
Great, perfect. Thank you.
Yep.
So I was saying that the ADOS is everyone's favorite autism assessment tool. This is an observation-based assessment where the child or teen interacts with the examiner who's giving the ADOS. And it's there's different activities that happen based on the child's age and communication. So what they're trying to do is create a situation that allows you to observe someone's social skills. So for example, for really young kids, one of the activities we'll do is we'll pull out bubbles and we'll blow bubbles. And usually if you have a toddler or a preschooler and you pull out bubbles, they get a big old smile on their face and they look right at you, right? And that's a social skill. So it's creating opportunity for us to observe that. Another thing that you'll see is if that adult holds back that bubble wand and doesn't give it, most kids are going to come over and say, can I have a turn or point or look at you and try to request more of that. And that's another thing that with some of the social and communication delays with autism, we might expect to see that impaired. So we've created an opportunity to observe in a standardized way some of these social differences. Moving up in development, if we're looking at maybe a school-age child, we would expect as a social skill that they'd be able to do creative and pretend play with action figures and have a good imagination, right? And they might be able to do that with an adult who's playing too and go along with that idea, have a give and take of ideas in their pretend play schema, right? And so that's a way where we're creating an opportunity to observe some of those developmentally appropriate social skills. Thinking about a teen, it might be more like talking about what their school day looks like, finding out more about their friends. How do they know that someone's their friend? Have they been in a romantic relationship? How did they know they were in a romantic relationship? Where do they want to live with other people when they're an adult? Where do they see kind of their future going? And so, and then also along the way, throwing out some opportunities for conversation. So they say, I want to move to Florida. And I say, oh, I just got back from a trip to Florida. And what do you want to do? You want to ask me about my trip to Florida, right? So it's creating an opportunity for that social give and take. There's a question in the box about identifying high functioning autism or Asperger's, and it's similar. So it's the same tool, the ADOS, and it's actually the same diagnosis. So when we say autism spectrum disorder, that also encompasses high functioning autism and Asperger's as well. There's a little bit of a terminology change in 2013 with the release of DSM5. And so they got rid of the word Asperger's. And so it's all autism spectrum disorder now. So same thing where you create those social opportunities through the ADOS and observe in a structured way some of those possible symptoms of autism. So at KU, our process is a little bit different based on age, and that's pretty common at other autism evaluation centers as well. So our process for young children is that we see individuals for a single 4-hour appointment. And during that appointment, we're keeping the parents and kids together in the same room the whole time. So a lot of times parents are sort of anxious about that, or their kids might be anxious about that because they got separation anxiety. But that's why we keep parents and kids together, because we don't want to assess separation anxiety. And then we usually have 2 to 3 providers at that appointment, psychology, speech and language, as well as developmental medicine. For older kids, we have a 2-appointment process. At the initial appointment, which is 2 hours in length, and with just one provider, so either an MD or a psychologist, we'll do an intake interview to get like a detailed developmental history, and also detailed behavioral history. As kids are older, there's a lot more history to go through, so we have to spend some time doing that on the front end. The nice thing about that is it also gives us an opportunity to provide some initial recommendations and next steps. And we can also do hopefully some helpful triage and say, yes, actually, this is sounding very like it really could be autism. I'm going to refer you to the next step and do some more evaluation. Or we can also provide some helpful feedback and say, no, what I'm really hearing sounds a lot more like depression or anxiety or something else. And let's get you started with some treatments for that. So really helping along the way to start getting some recommendations going. And then at the follow-up visit, if it's needed, we'll do a similar structure of that 4-hour visit with, we do 1 to 2 providers. And for these older kids, we do usually separate parents and kids, which is important so that the kids feel comfortable, sharing personal information. We're talking with teens about relationships and things like that, where we need to have some privacy. So kind of what does a typical appointment breakdown look like? We start with introductions, confirm to make sure we're all on the same page about what the reason for referral is, to make sure, if it is an evaluation for autism, or if it's not, we want to make sure we know that too, so we're following up on the right thing. Then we'll do some standardized interviewing and assessment. So this is when we'll do parent interviewing, we'll do IQ testing, the ADOS, and then we usually give families a break because we know kids can't sit through a 4-hour appointment, and also we need a break so we can actually score the assessments we gave. So we give families a break for about 30 minutes to an hour. And then everyone comes back. We've written a short report that has the diagnosis as well as recommendations. And we all go over that together and have a conversation. This is a time to ask all the questions. And this is also the time that each of the providers on the team will provide some recommendations. And then after the appointment is over the course of the next week, the providers are writing up the final report. So it's a longer document that has all the specific tests that we're giving and all the history. And then that's available to the family after about a week.
Leni, real quick, when you're doing a break for them, is there like a specific, do you tell them to go take a walk or get something to eat or drink, or should they bring something for their kiddos to eat or drink? I mean, does it make
COVID's making all this a little bit weirder. So it used to be that we would send families out to the waiting room and say, feel free to go and get a snack if you want to and come on back. But we don't have a waiting room anymore. So we usually either let families stay in the clinic room during their break and we just leave, or if they want to step out and go to the cafeteria and get a snack, they can. I am honestly not sure about our current policy on snacks given COVID. So I don't know that I can answer that right now.
Okay, thank you.
Yep. So, can a diagnosed child lose his diagnosis in the future? That's a really good question. So there's for the most part, we think about autism being a diagnosis that's carried forward over the course of someone's life. And typically some of those characteristics are present across time. There is like a small group of individuals who, when they're diagnosed young, no longer have that diagnosis as they get older. That it's more common that they would maintain that diagnosis over time. In that small group of individuals who don't maintain that diagnosis as they get older, often they do have co-occurring anxiety, ADHD, or OCD. So still things that would really benefit from some intervention and treatment. The other thing is sometimes we'll see someone who had an evaluation, but they didn't necessarily get some of those standardized assessment tools. And so whenever I have a family come to me for reevaluation, I always say, just so you know, there's a possibility I won't agree with the previous diagnosis. And if that's the case, I want to make sure you're aware of that and you consent to that. So that's another possible way that someone could lose the diagnosis in the future. Yeah, I'm sorry for muting you, Teresa.
I just wanted to ask, I wanted to comment something on this because it hits close to home for me. But I think one of the reasons why maybe somebody could be diagnosed at a young age and then no longer appears to have those same symptoms as they get older is because they learn how to adapt to the neurotypical behavior. Specifically your high functioning autism people, because they're intelligent enough, they're generally highly intelligent people. And I'll say that because I think my husband and my oldest daughter both have that. And what I realized and my oldest daughter was actually more or less diagnosed with selective mutism when she was a kid. We didn't do anything about it because she seemed happy and she did very well in school. But it took her till about I think her first grade year before she spoke to her teacher. And she's still a little introverted to this day, but she's happily married and has a child of her own now. So she did just fine. But when I was speaking to her about a year ago, and I was explaining to her some things that I had picked up on about her father, and we're still happily married, of course, but she broke down and kind of said she could relate to him. And then I knew something was connected there. And so it took me that many years to figure out that what I was dealing with was high functioning autism all these years. And that anxiety never really goes away. They just learn how to cope with the neurotypical society. They learn how to behave, in other words, to get along in society, but they still are dying inside is part of the problem, I think, anyways. So when we report that maybe some people appear to be better as they get older, I think what they're actually doing is developing a coping mechanism to get through life. So that's just my 2 cents.
No, thank you for that input, Teresa. I really appreciate that. And so I think what you're describing is that idea of like camouflaging, where some people kind of develop some of those coping skills and are working really hard, but the world is still a really uncomfortable place to try to manage some of those things that could be symptoms of autism. It may not be as outwardly apparent. I'm really interested in let's research it. Let's figure out a way of assessing what that looks like so we can better understand the small group of individuals who no longer meet criteria as they get older. I'll also put out there the devil's advocate possibility. I'm someone who, for a long time, I was really skeptical about this. I was like, I don't think so. I know autism. I know that's something that's typically carried forth over time. And I've seen it at least twice that I even was assessing for camouflaging internal states and things like that. And it just didn't make sense anymore. So that's why I'm like, let's research it and let's figure out a way to study this and better understand it, because I want to understand that camouflaging experience and I want to understand what that looks like across the lifespan. I want to talk a little bit too about reactions and emotions that people might have on evaluation day. There's the gamut, right? There's the full kind of range of emotions that people might experience: sadness, disbelief, anger, relief, joy, or a messy mix of all those feelings at once. Sometimes it's helpful for parents to have a support person available, either in person or via the phone. So think about that in advance as you're planning for that, the evaluation. And it's as a provider, it's a hard balance because you want to provide all the information because this family's been waiting for a really long time for this appointment. They really want to understand what's happening. And you want to give all that information and you want to set forward kind of that treatment plan and those recommendations for ongoing care. At the same time, that's an overwhelming amount of information to take in, especially while you're also just trying to process just the diagnosis. And so processing that information can be really hard and an overwhelming experience. And I think that's the case whether we end up making a diagnosis of autism or not. It can be equally challenging and a very also hard reaction when sometimes when families were expecting that they thought someone had autism and then it turns out they don't. That can be also really hard to process.
I can share from my experience, and I'll make this kind of short because I know we're trying to get through this. But I absolutely remember being told that my son Matthew had autism. And I didn't hear, as soon as I got that diagnosis, I didn't hear anything else after that. I was sad, I was in tears. And for several weeks after that, I was still that way, feeling the loss of the child that I had. But then I realized afterwards, he's not any different. It's just more information that I have to help him with. Yeah, some of my dreams for him had to change, but his dreams didn't change because he was still going in the same direction. So I think if you are sad, you need to take that time to grieve and get through it and talk to people about that, and then look to move forward.
Yeah, I completely agree, Stephanie. And so I also think after walking out of that evaluation, sometimes people feel this rush of like doing everything all at once. Because as parents, you want to be that superhero who's doing all the things for your kid. But you don't have to do everything at once. You can take that time to process and ask for the providers who are there, like pull them on their team, ask them, I can't do all this at once and I'm feeling overwhelmed. What should I do first? So just kind of take that time to pause and breathe and ask for what you need.
And that's the same thing when a family calls me after the diagnosis, what are the most important? And I try to give them the top 2 or 3, just focus on these. Once you've gotten those done, completed, come back, let's talk, and we can look at what the next steps are after that as well.
So the next thing I want to talk about, and if we have time at the end, I'll talk with Melissa a little bit more about diagnosing in girls, because that's a really interesting conversation. So as far as the next thing we want to talk about is sharing, because the point is not just to get that information at the diagnosis, it's also to think about what do we do next. And often the next thing we're doing is sharing that information with the people who are important to us. But it's also important to remember this is confidential health information. So it is the family, the guardian, it's their information. And so usually that does need to get shared back with the referring provider, who's often the primary care. And then also insurance needs documentation that an appointment happened and it was valid, and so they'll pay for it. But otherwise, no one else gets the information without parent consent. So it's up to the parent to decide who should you tell and why. What are the benefits of sharing and what are the risks? Some of the images I put on this page are related to neurodiversity, and often families are concerned about stigma, which I think is an important and thoughtful thing to consider. But I've also been in some ways proud of how far things have come, even though there's still a really long way to go. And I think that stigma is still there, but it's changing. And so I just want to put that piece out there. And so, Julie, I'll turn the mic over to you.
Excellent. So again, it is a personal decision, but to get a comprehensive team around the child or the individual, sharing these results with medical providers is very important. Outside school therapists who often in the reports, the diagnostic reports, we are making recommendations for goal areas or intervention approaches. Like I know for myself as a speech language pathologist, if I see a child who I already saw was using visual supports effectively, or I thought would benefit from a speech generating device, I will put in specific recommendations in my report. So often that's very important to share with other therapists. In terms of the schools, many of the children we see are already currently on an IEP. However, the choice to share with the school district can be made by the family requesting a meeting to discuss the evaluation results, and then also specifically to request that the exceptionality be changed to autism. Not in all school districts, but in some school districts, having that exceptionality listed as autism results in additional supports or services that are tailored for the child with autism. So that's kind of a really big benefit that not a lot of families know about right from the beginning. Also, there can be collaboration between sharing the recommendations and the goal areas for services. We often review an IEP and discuss, consider adding this or continue this. Again, the school district does not have to follow any medical recommendations. They do their own evaluation, but typically there is this nice relationship where the school district will want this information to help guide the IEP process and the student's success. Okay. So sharing with family and friends, this we wanted to cover, and there's a lot more information through the Autism Speaks website. There's actually a friends guide, there's toolkits on how to talk to family members. It is not unusual for spouses to maybe not be on the same page, or partners or grandparents or aunts or uncles or family friends. And so bridging that conversation can take some art. And so some of the suggestions that that we researched are to anticipate that your family and friends will also have a variety of reactions, and so to give some time. And then describing autism, some basic information on understanding what is autism and linking the behaviors that they're seeing to the symptoms of autism can really help. And then focusing again on the purpose of the diagnosis is to best benefit the child and get evidence-based services in place. A recommendation too is for a family member or friend who is struggling, give a specific ask for how they can help you and help the child. Also, another recommendation is use the report to your benefit. Now, the long drawn out report has a lot of developmental history, it has some family histories, maybe some information that you wouldn't want everybody to know. Maybe you wouldn't want the grandparents to know. But we do provide an after visit summary, which is less detailed, but still gives really pertinent information. So often we recommend to maybe first give that to a family member who's questioning or concerned or doesn't agree. Let them review it on their own time and then bridge that conversation. Again, we've linked all of our sites today, very reputable websites. And then it also is
Julie?
Yes.
Sorry, you keep cutting out.
Oh. Let's see here. Can you hear me now?
Yep.
Okay. So yes, and then some families, if it is causing significant stress, might also want to seek professional supports through counseling. I saw some comments in the chat, depending on the age group. Absolutely, Sesame Street has some new books. Daniel Tiger has some great shows on how to talk about autism with friends and other family members. So there are a lot of supports out there. Just make sure that you are going to some of these more reputable sites to help guide you in some of that information. Okay.
So I think another thing to talk about too is when do you tell your child or teen that they have a diagnosis of autism? That's something that, as someone who often does what we call the older kid clinics, I get to see the big kids, school age through teens, as well as the little kid clinics where I get to see 2- and 3-year-olds. You know, it comes up in some ways more naturally for the families in those older kid and teen clinics. So what I'll often do at the time of the appointment is give the family a choice about whether they would like for me, as we go over the results, to share those results and findings with the child as well. I think it's important to make sure that it's a choice that is made by the parents. In a study that we've cited here, there's a chunk of families, I think it was like 25 to 30%, said that someone else told their child that they had autism without their permission. And so I think that's something that really should be a parent choice. It's highly personal. And there's, I'd say most of the time families would like for us to go over those results together for older kids and teens because they know why they're there and they want to know the results. But there's also sometimes that parents have some also really good intuition about, no, this is something we need to have as a private conversation. And you want to make sure we're respecting the parents' wishes in that way. The other thing is that sometimes when kids are diagnosed really young, people aren't really sure like when to share that information. In this study, the average age of telling a child about their diagnosis was 6.5. But I think it's really dependent on parents knowing their kids. And I also think the information about diagnosis is shared in different ways at different ages. The same way that information about sexuality is shared with kids in different ways at different ages, right? So sometimes information might be shared with younger kids, more of like, you know, you're really good at some things, but other things are a little bit harder. So we're going to work on that. And there's never necessarily a diagnosis or label that's discussed. Or in other families, autism is a word that's a part of their household. And it's not something that ever comes across as like an unveiling or surprise because it's always been a part of our family language. I don't think there's necessarily a right or a wrong way to do it, but I do think that as kids get older, we want them to be able to advocate for themselves. And that often involves making sure that they know their diagnosis, and so that they can do that advocacy. You know, reasons that parents will often identify for wanting to tell their child the diagnosis is trying to understand that source of behavioral or emotional differences that they might be noticing from peers, and then also help kids learn strategies for success. For some kids or teens that are really aware that there might be differences socially between them and their peers, it can be a source of relief for some people to know there's a reason, and it's not because I'm bad, and it's not because I'm not trying. There's a specific reason for why this is happening to me. And so that can be helpful. You know, kids can have a variety of reactions. A lot of kids feel curiosity. A lot of kids I talk to feel confused. They can also feel relief or happiness, like I said. I've had a lot of kids who are like, feel really happy to find out they have autism because they have a friend at school who has autism. And so they feel like they have that community. But I've also seen kids who have a feeling of anger or sadness about that information too. But we also know that kids who are aware of their autism diagnosis are better able to understand their strengths, as well as areas of weakness, and can advocate for their needs more strongly and are better able to cope with setbacks. A lot of times families want to know how should I tell my child or teen that they have autism? So when I share this information with kids and teens, I always start first with strengths. So we got to know you today and we found out you're really good at some stuff. For example, I recently saw a kid who's amazing at space, knows everything there is to know about it, and it's a real strength that they have. And then I also think it's important to say, we also learned that you have something called autism. Do you know what autism is? Have you ever heard of that before? Do you know anyone who has autism? Because often kids might have misconceptions about what autism is. And so it's really important to find out what they are already thinking of or they know related to that. And then we want to talk about the fact that there's some parts of autism that might be really positive for the child. So like I said earlier, autism might make someone think about things in cool and unique ways that might be different than the way other people think about things. And that's awesome. And that comes from your autism. Or autism might make it so that you're really good at remembering schedules, or you're awesome at learning about space and other people can't do that. That's something you have that other people don't, and it's because of your autism. So emphasizing those strengths, but then also acknowledging there's parts of life that might be more uncomfortable because of autism. So some people with autism have a harder time knowing what to say in conversations, or might feel really uncomfortable like you do when you hear sirens. And that's because of autism. So being able to identify these are some of those concrete things. But now that we know that, we can better get you some help or support for it. or now that we know that part of you, we can make sure that's why we do these things. That's why we go to this therapy. We do that to try to help you because we know about that part of autism. One thing that I often find is helpful is that kids get this like spotlight effect. They feel really different from their other peers, and they don't necessarily like that, right? So I often say, like, do you know how common autism is? And kids always say no. And it's 1 in 59 people right now. So think about how many kids are in your grade at school. How many kids are in your school? There's other people there who have autism, and you can't tell just by looking at them. And so people may not be able to tell that you have autism just by looking at you either. So that can help them not feel quite so spotlighted that other people experience this too. And that can also lead to a nice conversation about, if you decide you want to tell, the only way people would know you have autism is if you tell them. So we have to decide together. Are you going to tell your friends? When is the right time to tell a friend? How close should you be to someone before you tell them about your autism? And that's kind of a conversation about consent and about privacy, right? And so that can be a helpful conversation for families to have too. And then finally, just like sexuality or other big conversations you have with your kids, this is never a one-time thing. So making sure it's clear that the door is open for ongoing conversation, because this is not just a one-time thing. Let's talk about it tomorrow. And if I don't know the answers to questions you have, I'm going to go find out. I'll talk to the doctor. I'll talk to your therapist. I'll talk to your school. So kind of leaving that door open. There's a great question about person-centered language versus disability first language. And I don't think there's a right or a wrong way. I think what you want to do is make sure you're being respectful of people's wishes and desires. So this booklet that I have here is called Welcome to the Autistic Community. So a lot of adults with autism prefer disability first language because they see autism as an important and valuable part of their personality, and not something that's like on them, like a disease has been kind of attached to them. So kind of like I might just describe myself as a Midwestern woman, someone might describe themselves as an autistic woman. On the other hand, other people feel like that puts too much emphasis on the autism, and so they prefer person with autism. You don't know until you ask someone. So I think I encourage you either to ask or follow someone's lead. So I usually start with disability with person first language, because that's the preference of a lot of the parents that I work with. But once I hear someone using identity first language, I can switch. And then I would reflect that going forward or ask to clarify. The other reason I have this picture of Welcome to the Autistic Community on here is one of my favorite resources for families of teens, especially if they're going to have the conversation about autism without me, is there's this booklet written by the Autistic Self-Advocacy Network that describes what autism is from an autistic person's perspective. And so I think it's a really nice way to describe strength-based description of autism. It's a free resource, so check it out. And the last thing that I want to cover is that another important part of sharing is connecting with other people. And that could be, as a parent, connecting with other parents. Thanks, Stephanie, putting resources in the chat box. I love it. So the Kansas City Autism Spot is a Facebook group that has a lot of parents connecting with each other on there. And there's also a lot of autistic adults who follow that as well. The Autism Society of the Heartland is a great resource, and there's lots of other ones across the state. This is just like 2. KCART, which is one of our partners and Stephanie's a part of as well, is a great resource for ongoing connection with parent support, as well as finding about resources and things in the community. And then we also know it's really important for teens and adults with autism to connect with other autistic adults. So Kansas City League of the Autistics is our local self-advocacy group. And they've recently gotten some been reinvigorated with some great people. So they have a Facebook page and they have some events too, and they're a great resource. And so I'd like to transition now to some questions. And then also, Stephanie or others, if you have additional resources you want to share related to connecting with other people or individuals with autism.
No, I think we've covered a lot of the ones that I suggest. The one thing I would say is some people are like, well, we don't have, because this is anybody anywhere can be watching this right now. So I want to say, if there isn't a local parent support group, reach out to somebody, ask the teachers if there is another parent in your school, child's school that might be willing to meet with you. Even if it's just two of you and you go and have coffee, you're starting to build your support network right there in your local area. And then I also encourage, hey, next time, let's each invite one more person to that meeting the next time you meet. And even if only one other person shows up, there's three of you. You're constantly growing that and helping each other. So I would encourage that for sure.
I saw a question from Teresa in the chat box. Is it anxiety that keeps them from having conversations, or is it something else in the brain that keeps them from original thinking or innovative thinking? That's a great question. I have some thoughts, but Julie, I also didn't know if you, as the speech language pathologist, if you had thoughts about that too.
I think again, it does depend if the individual also has a co-occurring speech and language disorder. So a receptive and expressive language disorder, meaning they have a hard time actually accessing the words, picking the correct words, and then forming them in correct sentence structures. That can also make conversations very difficult. So I think it depends. Now, not everyone with autism has a language disorder, but everyone who has autism does have difficulty with that pragmatic language aspect. So the actual rules of conversation and understanding more figurative language. So that can make it challenging. I'm not sure if that answered your question though. Do you have anything else, Dr. Swails?
Well, I mean, the other thing that we could do a whole other talk about too is looking at some of the brain differences related to autism. So I think the question is it anxiety or is it autism or is it the brain? I think the answer is yes. All of the above, because language involves brain functioning. We see differences in brains of people when they're experiencing anxiety versus not, right? So all these things are interconnected in a really interesting and messy kind of way. So that was a really good question. There was also a question earlier about the complexity of diagnosing girls with autism. You guys aren't like holding back with your hard questions. Thank you. So girls are really interesting and fun too. We know that the presentation of autism can be slightly different in girls compared to boys, and they're more often missed, which I think has become much more like apparent in the media too. So I think that everyone's starting to understand that a little bit better, but there's still a really long way to go. I do typically still use the ADOS when evaluating for autism in girls. Oh, and we got the Girls Night Out program. They're currently having an event right now, which is our social skills group for girls, for teens and young women with autism. I do typically use the ADOS in girls as well. I think you have to have like a fine-tuned eye to look for some of the different characteristics of autism in that population. For example, we know from some of the research that that preschool and toddler girls with autism are more likely to have better pretend play skills compared to boys. And so I've sometimes heard people reassured families and said, oh, but they've got great pretend play skills. I don't think they have autism. And then are kind of missing that there's other parts of autism that are happening. Girls also tend to have less impairment in language when they have autism, so that can be missed, and can have better eye contact. So some of those hallmarks that people might look for aren't necessarily there, but they still have some of those other characteristics of autism. But we also know that even though some of those characteristics of autism may not be as overt, that that girls with autism still can have significant impairment and distress related to some of those things. And especially when they're having kind of like what I think it was Teresa earlier was describing, is that internal distress and that kind of like experience of masking or camouflaging. So we also know that girls with autism are at higher risk for anxiety and depression. And I wonder if it's related to that kind of extra burden of being under recognized for that, and then also having to carry around that kind of distress internally and some of that discomfort.
Well, we are getting down to the end of our time. I want to thank Dr. Swails and Julie Mujica for sharing with us tonight on this. I know that families, when they hear their child needs an autism evaluation, they get really nervous and scared and sometimes just want to know what's happening. And that's the main reason I wanted to get this training put together and shared. Again, I shared it earlier, but Kansas Lend has a YouTube page and we put all of these sessions out there. It won't be out there till next week. I don't work Fridays, but it will be out there. So if you ever have a family that you are referring and they need this information, please share that YouTube page with them, the video from tonight, because I think it's really important that they kind of have a better understanding of what it is going into this. I remember I just came into it. I didn't know what to expect. So I'm really excited about having this recording. And then I just want to share next month's session is the Kansas Special Healthcare Needs Program. Kelly Toddy, the program manager at Kansas Department of Health and Environment, will be with us on October 14th. From 6 to 7:30, and there'll be some more information on registration going out next week on that one as well. So if you have any additional questions, you can always email them to me at scoleman3@kumc.edu, and I will work to getting those questions answered for you. But until then, thank you for joining us. We really appreciate it. Have a great night.
Thank you.